Good morning. My name is Amit Thudke. I'm one of the third year resident from Augusta University Medical Center. But the topic of our clinical vignette is a case of COVID-19 associated Guillain-Barre Syndrome. Roughly around one third of hospitalized patients with COVID-19 suffer from some type of neurological disorder which ranges from myalgia to encephalopathy. In this clinical vignette, we present a case with progressive cervical weakness after contracting COVID-19 infection was confirmed to have Guillain-Barre syndrome. A 63-year-old African American gentleman presented with progressive bilateral lower extremity weakness of 2 weeks duration. He denied having any visual, sensory changes, trauma, or back injuries, or any fecal incontinence. He reported having household contact of COVID-19 infection. On neurological exam, he was found to have decreased strength in bilateral lower extremity along with absent deep tender reflexes in the knee joint and the ankle joint. On laboratory findings, he was found to have elevated white cell count of 11.4, ESR of 41. His COVID-19 nasal swab was positive. Other workup of folate, B12, and RPR were negative. We obtained a lumbar puncture which showed within normal range of glucose, white cell count, and RBC, but total protein was slightly elevated to 13.9 along with oligoclonal bands. No conduction study showed absent or diminished amplitude in sensory responses and absent F waves. Chest X-ray showed mild hazy lung opacities bilaterally consistent with cold pneumonia. MRI with contrast of the spine demonstrated enhancement of the cauda equina along with focal enhancement at thoracic chords of T11 and T12. So the laboratory findings in correlations with signs and symptoms confirmed the diagnosis of Guillain-Barre syndrome in the setting of COVID-19 infection. Our patient was treated with IVIG with significant improvement over 3 weeks. He was also treated with remdesivir and dexamethasone for his COVID-19 infection. Novel coronavirus SARS-CoV-2, or also known as COVID-19 popularly, is a virus of coronavirus family. It gains access through ACE2 receptors, which is found in multiple organs, ranging from nasopharynx to the nervous system. So GBS is a rare debilitating autoimmune polyneuropathy is associated with gastrointestinal and respiratory viral infections. So the body produces antibodies to combat these viral infections, which cross-react with the gangliosides of the neurons, as shown in the figure 4. One of the first established cases of GBS was in Italy by Toscano et al. IVIG is very effective treatment for COVID-19 infection as any other GBS, which shows prompt improvement in the weakness. So our take-home point is to have this differential in mind when someone presents with lower extremity weakness in the setting of COVID-19 infection, and we believe that further studies need to be done to ascertain the relationship between COVID-19 and GBS. Thank you.